Hello, my name is Patricia Steger from the University of Providence. I will be doing an oral defense of my capstone paper entitled Implementation of Perioperative Glycemic Control in Non-Diabetic Spinal Fusion Patients to Prevent Surgical Site Infections. High perioperative glucose levels are associated with surgical site infections. Recent SSI prevention guidelines strongly recommend management of perioperative glucose in diabetic and non-diabetic patients. Current protocols exist for diabetic patients, but not for non-diabetics. This project describes the development of a protocol for non-diabetic patient population. Gaps in contributing hyperglycemia-related factors in current protocols were identified. Interventions including establishment of standard dexamethasone dose and perioperative glucose monitoring. Short and long-term goals were 25% reduction in hyperglycemic patients and an annual standardized infection ratio decrease to at or below the national baseline. The Capstone project was carried out at a 434-bed tertiary hospital in Orange County, California. The hospital has an extensive neurospine program performing approximately 1,300 annual procedures, including craniotomy, spinal fusion, laminectomy, and ventricular shunt surgeries. The program has experienced a higher number of surgical site infections than predicted, as evidenced by a standardized infection ratio above the national baseline for the past 2 years. Spinal fusion surgeries were identified as the major contributor. Surgical site infections account for 20% of all healthcare-associated infections and occur in 2 to 5% of patients undergoing surgical procedures. Surgical site infections are associated with increased morbidity, mortality, longer hospital stays, and additional healthcare costs. Current published evidence-based SSI prevention guidelines strongly recommend the implementation of perioperative glucose control in patients with and without diabetes. The NSP program has implemented all current SSI prevention recommendations except for perioperative glucose control in non-diabetic patients who constitute the majority of neurospine population. Therefore, this project's goal was to implement these recommendations in these non-diabetic spinal fusion patients. A limited literature search was conducted for articles from 2009 to present. Articles published prior to the 2017 CDC SSI prevention guidelines were mostly empirical studies and narrative reviews discussing the occurrence of perioperative hyperglycemia, its causes and effects on surgical outcomes. Articles published from 2018 to 2020 focused on ideal glucose target levels, treatment recommendations, and hospital-developed protocols for non-diabetic patients. The empirical studies provided evidence for perioperative stress-induced hyperglycemia, which is a normal response to surgery, and its association with greater SSI risk, morbidity, and mortality in patients with and without diabetes. The studies also point out that the non-diabetic population will include some unrecognized diabetics and pre-diabetics. It has been recommended to screen on day of surgery when the patient is fasting as an opportunity to identify patients with impaired fasting glucose for postoperative follow-up. Several articles identified perioperative medication use, such as dextrose and dexamethasone, as a predictor of higher maximum glucose levels in non-diabetic patients. A meta-analysis found that glucocorticoid use caused glucose concentrations to peak during surgery or within the first 12 hours after surgery, and that it has a dose-dependent relationship to hyperglycemia. Studies found that hyperglycemia occurs in about 80% of non-diabetic patients, and that the SSI risk increases approximately 30% for each 40 milligrams per deciliter increase in blood glucose levels. The question of the ideal perioperative glucose target level is still unanswered. Studies have found that postoperative glucose levels greater than 140 were a significant predictor of SSI. Lewin's three-step change theory fits best with this project's structure, aim, and goals. In the first step, known as unfreezing, the current situation moves away from the status quo as participants recognize the need for the change and are motivated by a sense of urgency to identify problems and conceive solutions. In the second step, known as moving, requires looking at the change as a process and designing a detailed plan to engage participants to trial the proposed changes, along with coaching to overcome fear and uncertainty, with the intention of achieving targets that establish a new and better reality. In the third and last step, known as freezing, the change becomes part of the current practice, but must be sustained by balancing the driving and hindering forces, achieving a new equilibrium. Lewin's theory has the advantage of being simple to use, easy to understand, and effective when used in a top-down change project, especially when change champions are employed. There were several key people that were necessary to have for this project. The MSI student and preceptor facilitated the formation of the group. The medical director of infection prevention provided expertise in infectious diseases and epidemiology. The manager of infection prevention provided a liaison between IP and the work group. And the medical director of the NSB program and the surgeon champion provided leadership for the work group. The surgeons provided surgical expertise, suggestions, and potential glucose control measures and feedback. And other representatives, such as perioperative nurses and educators and quality improvement, provided their expertise, suggestion, and also other potential glucose control solutions. Information technology provided support for the electronic health record, suggestions for IT solutions, and anticipated any implementation barriers. There were several barriers encountered during the project. First, lack of neurospine surgeon buy-in was overcome by collaborating with the infection prevention medical director to engage the neurospine medical leadership and show evidence for implementation of glucose control in the non-diabetic population, and also enlist a neurospine surgeon champion. Second, there was potential concern for increased bedside nurse workload and testing cost due to periodic glucose level monitoring in a new patient population. Bedside nursing staff participation was essential to define a workable schedule and method for glucose testing. Additionally, bedside nurse education on the importance of glucose control to prevent surgical site infections supports the rationale for testing in non-diabetic patient populations. Third, there was difficulty accessing necessary clinical data from the EHR, such as glucose values and medication use with administration dates and times, necessary to monitor project efforts. A partially validated glucose result report for neurospine patient population was available in a separate information system. However, available EHR medication reports were found to be invalid. Therefore, an IT business intelligence custom report request was submitted and a new report was created. This will allow easy process monitoring, tracking, and trending, useful for feedback to stakeholders. There were several aspects of this project that went very well. Strong support from the infection prevention medical director, as well as financial incentives tied to surgical site infection reduction, facilitated surgeon interest and involvement. The ability to present affiliated hospitals' perioperative glucose control protocol data and positive outcomes also increased surgeon buy-in. Perioperative leaders and educators are aware of the need for surgical site infection reduction and are motivated to support the launch of the protocol. Electronic health record order sets have been created and are available for adoption. Guidelines serve as a starting point for the delivery of evidence-based care, but they are only useful if they are implemented successfully. Hospitals must engage individuals at all levels, from frontline providers to leadership. The work completed for this capstone project has enabled me to become more comfortable with presenting scientific evidence, its application for clinical care improvement, and resultant outcome data to engage and motivate clinical leadership, physicians, and clinical caregivers to incorporate evidence-based practices. It has also helped me refine my PowerPoint presentation design skills to better capture and retain audience attention, which will make me more effective in future roles and projects. Several key interventions, including robust data tracking, efficient feedback mechanisms, use of evidence-based bundles, and safety culture improvements, are necessary to effectively implement a successful SSI reduction program. All these interventions were part of my Capstone project, and being able to develop, plan, and operationalize them was a good learning exercise that I can translate to future infection prevention program implementations.